Hello, thank you for joining us. I want to introduce Janet Tully. She is from Honor Health in Arizona. So I'm going to let you introduce yourself, Janet, and what your role is and who you oversee.
All right. Sounds good. Thank you so much for having me. I am a clinical quality program manager at Honor Health. And the way that we do clinical quality, we have service lines. And so my service lines are the emergency department for all of our 6 main hospital campuses and then 2 freestanding EDs. And then I do sepsis for the network as well, and that's for our 6 main hospital campuses.
Great. Wow, that sounds like a big job. So we'll go ahead and get started. Today we're talking about your endeavor and your process for implementing a sepsis alert. So tell me a little bit about how did you know that's what you wanted to do?
So it's very interesting. I was a bedside nurse working night shift in the ER, and back in, I want to say it was 2006, it could have been 2007, there was an ICU nurse that floated down to the ER, and we were talking about septic patients, and she felt like we could do better care with them. And so a opportunity for a nurse evidence-based practice program came up, and my director sent me and her director sent her. So we did our project based on sepsis. And we were able to work with the quality nurse at that time and find out what our mortality rates were. And then we reviewed the literature to see what is best practice and how do we reduce that mortality rate. And so fast forward several years later, we had implemented a basic sepsis order set with the ED physicians back then, and the quality nurse retired, and then I got this role. CMS had just rolled out sepsis as a core measure, and so there was now the whole system was involved in a network program. So they got together myself and an ED physician champion, which is absolutely critical. If you don't have a physician champion, that is the first thing that you should work on. And so we got leadership buy-in to put together a group of people. We had a respiratory therapist, a pharmacist, bedside nurses, ED educators, and we all looked at the practice project that we had done years before to look at that evidence, and then we also looked at current evidence. So what we came up with was we could actually train the respiratory therapists who are actually part of the lines team. They put in lines for patients throughout the system, and it's a small number to train. And so we trained them how to notice suspected infection or known infection, to SIRS, and then how to run a lactate on a point of care machine. So we used to use iStats and now we use ABLs, but by training a small amount of people throughout our system, they were able to, when a sepsis alert was called, they would respond, and then they would have a conversation with the nurse and the physician. At the same time, We did educate all of the nurses throughout the system through HealthStream, and they get that when they're hired. We created a pathway so that the sepsis alert team, the nursing staff, and the physicians all had the same pathway. We created an order set for the physicians that they could easily click, and all components of the bundle were in there. They could unclick them if they wanted, but that's kind of how our system started with a sepsis alert.
Okay, so I'm going to dig a little deeper into the actual sepsis alert piece. So how does that work? Who gets to call that? Is it overhead? Is it through a phone system? Is it a pager? And what was your first step in starting that?
All right. We made it a sepsis alert where the physician or the nurse working in the ER, or I believe a respiratory therapist has it available, could put in an order into the electronic medical record called sepsis alert. That order goes to the patient care tech or health unit coordinator to page the respiratory therapist that is assigned as a sepsis alert person of that day. And so when the ED, or actually, I'm sorry, I'm only focusing on ED. This is actually not just the ED. This is any area in the hospital. Any area can call the sepsis alert team, and it is a respiratory therapist that will come to the bedside and evaluate the patient with the nurse. There could be a physician evaluating at the same time. And so we do have an order set for the sepsis brief, we call it, so that the nurses are empowered to call the sepsis alert team and run a point of care lactate without a physician being there right then. But of course, they're going to call the physician and let them know, what they're seeing. And a lot of times the physician will already be involved in the care when all of this transpires.
So it sounds like you really needed some help from the respiratory department. That's not your usual suspect, I don't think, to respond to your sepsis alert. So how did you get their buy-in or that department's buy-in?
Yeah, it's very interesting. We had a great respiratory director that we connected with who said, you know what? Our department actually responds to rapid response calls, and we could train them about sepsis because a lot of times septic patients needed an additional line put in for antibiotics, blood cultures, all your labs and stuff. And because they were already there, they agreed to train their staff. Initially, we were thinking we could train the rapid response team, but when we looked at the numbers of nurses that are on the rapid response team, it was a much bigger number. So we were just trying to get more bang for the buck and train a smaller amount of people. We did train the rapid nurses as well. They received the HealthStream, but it's so much easier to train a smaller group of people than 5,000 nurses. So we called it shepherding the process. So the sepsis alert team, we called them experts in septic care, and they worked very, very collaboratively with the nurses and the physicians.
Well, and it's so nice to have a volunteer sort of, and to have that well, it sounds like you really created value in the position for them so that they could feel valued about their work and then have great accountability about it. So
Yes.
tremendous. That's great. So it sounds like you were looking at data when you decided you needed to do this as well. Did you need any additional resources or any additional data when you were rolling out your sepsis alert?
Yeah, I'm glad you asked that, because one thing that you need when you go to find a physician to support this program, you need to have data. You need to have, where are we at right now with our mortality in the hospital, and where are we at with bundle compliance? And so when I was looking for that information, back when I was a bedside nurse, I went to the quality department and they were able to give me those numbers. Some of the physicians that I approached initially did not believe the numbers, and they did not believe that we needed to implement a program. So it was kind of interesting to me. Um, I had to get a little bit creative to get buy-in from the physician. So as the more I read articles from our journals, from whether it was a medical journal or specifically emergency medicine journal, there was a lot of evidence out there. There were other systems that were implementing sepsis programs. Some would call them code sepsis, some would call them sepsis alert, some would call overhead. I needed to share with them those articles. So I saved them and emailed them to them. So I definitely did a lot of research to make my case. And then also finding out a couple of our physicians were actually trained at the same hospital system where Manny Rivers, some people call him the godfather or the starter of sepsis care in a timely manner in the ER. I found out some of our physicians actually went to school there and he was their professor. So that was kind of helpful to me, for me as well. You know, I would say, wow, what would Manny Rivers think if he found out, you know, our system doesn't have any type of sepsis protocol. And so you know, just thinking of little things, because when you meet with a physician to get them to champion your cause, remember, they're going to have to take that to their colleagues who are maybe going to give them a little pushback. And they're also going to need to take it to leadership along with you to figure out what's the return on the investment. And we were able to show easily lives saved was our return on investment. We also did get some data that showed length of stay would go down, you know, so there were some money saving items as well, because our initial program request was to get bedside point of care for the lactate, which wasn't cheap. The hospital system need to make an investment. And then also to add order sets to the electronic medical record, that's costly as well. So, you know, thinking about how can you leverage your leaders to buy into this. So we went at it from many angles.
I think we often have to do that when we're initiating a project. I love that you recognize and share that, you know, physicians are scientists at their heart. So you need to provide data and literature to support any kind of change and what's going to make their lives better too, right? And their patients, because they want the best for their patients. So what's going to help their patients? So
absolutely.
Thank you for that. So did you select an improvement strategy when you started to roll out your sepsis alert, or did you just go for it? which is either one's okay. Just
Yeah, we actually worked with a nurse who specializes in sepsis care, Pat Posa. She's from the Midwest. She came out and did education for our physician group, and she had some really great suggestions because you can't just throw a project out there and not have a way to measure whether it's successful or not. So we did PDSA. So we planned it, we studied it, we implemented it, and then we went back and evaluated to make sure was everything working right? You know, did the sepsis awareness team actually show up? Did they do education? Was there good communication between the teams? How quickly were the antibiotics being given? How consistent were we at ordering the order set? And then the biggest thing when we reassessed, we looked at, did mortality go down from the time that we started the bundle process until I want to say we reevaluated in 6 months, but it's been so many years, I can't remember right now exactly, but mortality was going down. So we knew we were going in the right direction. One thing that we were not always successful with was the nurses activating the sepsis alert. They were waiting for the doctors to do it because there seemed to be a little bit of pushback at that time. But once the nurses, you know, got empowered and, you know, they got positive feedback, and we also shared with them, here's what mortality was, here's what it is today, thanks to you recognizing that patient. And so another thing that we did that we noticed when we did the PDSA cycle is that antibiotics were not always readily available in our Pyxis. So, you know, it depended on what the physicians were ordering. So that's where pharmacy came in. With the order sets, they actually came up with a list of most often given, and then they made sure that those were readily available in the Pyxis, that once they're ordered, you know, the nurse just gets them out and gives them very quickly. So I can't think of anything else that we had to kind of go back to the drawing board. Our order set did change based on physician feedback to make it easier for them, you know, making sure there was a chest x-ray option, you know, other things like that. The labs that they consistently would order on septic patient. Here was another one that we were kind of missing. We were not always drawing the blood cultures prior to giving the antibiotics. That was a challenge. Just getting the physicians to order it was a challenge because I want to say there was a CMS metric related to pneumonia and blood cultures a while before our project started, and CMS got rid of that because it was not a good, efficient cost of care to always do blood cultures on patients with pneumonia. But so that was kind of hard to get the doctors, hey, you know, if this is a severe sepsis or septic shock patient, you know, order those antibiotics early and then train the nursing staff or the sepsis alert team to make sure they drew them prior to starting the antibiotic. So that was a little bit of a challenge too.
I've seen a
So we
couple
just actually we're still doing the PSA cycle, PDSAs.
Yeah,
Yeah,
it's sort of throughout the livelihood of a project, the lifetime
yes,
of a project, I should say.
yeah.
So one question, if you could look back and coach yourself from your current perspective, what advice would you give yourself?
I would say read some articles ahead of time to get ideas on who you need on your team, and then recruit some key people. If you mention mortality, you're going to get buy-in from anyone working in healthcare. But getting those people to be part of your team from the beginning is really helpful. We had a nurse practitioner that was actually helping us at the beginning, because the way that I was reading articles, I was not always finding valid, reliable articles that were really good studies. And so she helped us create a matrix with the highest level evidence down to opinion. And so we put it in a specific format so that when we were going to the physician group and to the leaders, they could see the level of evidence that was out there. So I think, going back, I would have definitely read a lot more articles and gotten a lot more data, because you really need valid, reliable articles that you can argue for starting the bundle as quickly as possible, and what components of that bundle you need.
Right, right. Okay. Now, as you work through the project, did you have any like aha moments or any unforeseen challenges or unintended consequences, either good or bad?
I think we had some leader turnover. We did have a respiratory director who was really all about, making this sepsis alert team part of the process, and he left our organization. We did get another respiratory director to take over that leadership role, but he was from a different campus. So that's a challenge when you have changes of leaders taking over. It was really important for us to put things into place that no matter who takes over, they can see standard work has been done and there's an accountability loop. We have struggled with an accountability loop whenever there's been leadership changes. So yeah, that's hard.
Yeah, we have to have projects that are sustainable no matter who's in the building, right?
Oh yes. Oh
Yeah.
yes, for
Um,
sure.
so anything else you want to share about your sepsis journey, or tell anything you want to say to encourage others, or
Um, I would just say, put this information in front of the top leaders, your chief medical officer, your chief nursing officer. They are the ones that can get you resources and that also can support the accountability loop. I've noticed, although I was a bedside ER nurse for more than 20 years, and when I was working at the bedside, the physicians were always open to my suggestions. I noticed when I came into this role in quality, not all physicians like to hear from a nurse. Some of them like to hear from a physician. So, making sure that you have a physician that is passionate about this work and willing to have some hard conversations.
That's great. That's great. Thank you so much.